We have seen angina and myocardial infarction separately. We have seen that how they are important, how we are going to treat, what are the situations and what are the treatments. We have seen various guidelines for that. We'll combine this together. Let us see what happens. Now, basically, in both cases, these are coronary artery diseases, and therefore we call them as a coronary disorders. One is acute, one is always acute, that is myocardial infarction, while angina can be either acute or chronic, depends. Now these are the various blood vessels. We have seen it earlier also, and these are blood vessels. If any of these are occluded, then the area which we call that is distal to it. If you remember anatomical terms, proximal or and distal. So if any area which is distal to any of the arteries, if it is that artery is blocked, then that will going to cause the problem. We shall see some of the images later also. Now this is the microcirculation which is going on. If somebody insert the dye, then we can check that these are the blood vessel and how these fine capillaries are there, which are reaching to each and every portion of the heart. This is a coronary artery without any problem, but if you see that this is the atherosclerosis plaque. Now in MI or in angina, in both cases atherosclerosis is a main culprit. In most of the cases, because in some cases it can be other reasons also which is causing problems, but in most of the cases presence of, you can see the difference in the lumen size. This is the lumen size and this is the lumen size, which is atherosclerosis. Now what happens because of this, how we will differentiate between angina and myocardial infarction. So see, this is atherosclerosis, this is the artery, and here somewhere this in coronary artery, this is the first figure, there is a atherosclerotic plaque is growing, and we can call it as a phase 1, grade 1 to grade 3 of angina. So this will only show some action when people is having heavy exercise. Actually otherwise there will be no symptoms. Okay, then very heavy exercise, then only some of the symptoms can appear. Then next is a phase 2, where you can have, we can see there are still growth in this atherosclerotic plaque. The plaque has increased. Now we can have two varieties of it. Here there is a growing and the lumen has reduced, so it has converted from this stable angina to unstable angina, because even during rest, now this will show during exercise, the symptoms will be, it will show during rest only, and thus it is a fit case of angina pectoris. Now another case is there. Here it is plaque is there, and simultaneously there is inflammation other side. This has caused total blockade. Okay, now either it can be treated simultaneously, or it can become a acute syndrome, which can be a myocardial infarction. We can call it as an unstable angina, or it can cause ischemic sudden death in people. Okay, so this is how it is there. And lastly, phase 6, suppose this is not happening, then phase 6 will be there, where we can have this big problem, and later this has to be hospitalized, it has to be treated. So these are depending on the various situations, that how the plaque increases, and accordingly what can be the situations. So we have got two things, either it can be acute, example coronary artery diseases. Example of this acute is myocardial infarction or acute coronary syndrome, that is ACS, while chronic is angina. There are two situations like that. Now acute coronary syndrome, we call it as it is a tip of atherothrombotic iceberg, means whatsoever appearing, whatsoever is iceberg, you must be knowing, that is the smaller 1/3 or maybe sometime even 1/5 or even less than that portion comes outside, and the major portion is remaining below the sea. and therefore these icebergs are there, in that the person which is below the sea is not known, and it can be very dangerous. um, um, it can cause a big harm. So this is tip of iceberg, because clinically we can see that there is a plaque rupture, there are a problem. We can see that there is because of that there is either admission due to MI. We can see either non-STEMI or STEMI type of angina, or unstable angina, or myocardial infarction. These are the signs which can be seen clinically. But those signs which may not be seen immediately, there can be presence of multiple plaques. So usually it comes in picture when people go for angiography. Then they can realize that at many places multiple blocks are there. Then there can be persistent hyperactive platelets, so it can be acting at any time and can cause. There is a vascular inflammation, and that inflammation can give rise to even narrowing of the artery. So these are various consequences, or various actually unknown or less diagnosed facts which are there. Now Canadian society, that is Canadian Cardiovascular Society, grades it the angina in different way. We have seen earlier stable, unstable, prinzmetal, etc. This makes it in different way, that is class 1, class 2, class 3, class 4. It doesn't make much difference. Only thing is understanding is normal physical activity do not cause any pain, that is we call it as a stable angina. But when somebody is strenuous or rapid or prolonged exertion, then it will start showing pain. Class 2 is slight limitation of the ordinary activity. Angina occurs on walking or climbing stairs rapidly, walking uphill, walking over stair, climbing after meals, or in cold, in wind, under emotional stress, during that it occurs. So these are class 2. Class 3 are the having marked limitation of ordinary physical activities. Angina occurs during walking only, even few meters, even small walking, brisk walking, even it can cause, or climbing only one flight or only one floor, that can even make a problem. And class 4 is inability to carry on any physical activity without discomfort. Anginal symptom may be present during raid. These are the class 4. So these are all the stages, minor stages between stable to unstable. All stages are covered slowly into it. Now what will happen? What are the algorithms for that? Now let us see algorithm briefly. This algorithm are there. So what is the sign? That is clear, that is chest pain is there. If it is moderate to high probability, whenever there is a chest pain, we can say that is a moderate to high probability of coronary artery disease. Then check, go for diagnostic. It can be high risk, it may not be high risk coronary artery disease, but yes, there is there, risk is there, and accordingly it can be checked, it can be verified. Now if it is not severe one, then educational program, that is we have seen lifestyle management is very, very important. It is very helpful, it can be done. But if these are slightly major one, then go for anti-anginal treatment. It can be like sublingual nitroglycerin or isosorbate dinitrate. All these drugs we have seen in pharmacology. Then if history shows it is a vasospastic angina to what we call as a prinzmetal angina. We have classified it as a prinzmetal. So because of vasospastic, that means there is a spasm in the coronary artery. So here no plaque is there. We have seen that it is not always plaque. So give the calcium channel blocker or long-acting nitric therapy, that should resolve it. If the medications are condition that provoke or exacerbate angina, check it out. If these are there, then accordingly you should treat it. And if it is successful, then we'll see what it has to do. If it is not there, then add beta blockers therapy. If there are no contraindication, example in case of asthma or in such cases, so beta blocker can be added. check out. If it is successful, it is fine, then we'll go for follow-up treatment. If no, then add substitute or substitute calcium channel blocker, means beta blocker plus calcium channel blocker, or take out beta blocker and replace it with calcium channel blocker. If no contraindications are there to calcium channel blocker, check it out. If it is successful, go for it. Then add long-acting nitrate therapy and check out. So these are various. Then consider revascularization therapy. What are revascularization therapies? So by either if it is severe block, if it is severe problem, then we put angioplasty so that the person will have enough or proper blood supply to this one. So this angioplasty is one of their. Even after angina, it can be put. It is a sort of prophylactic so that it can prevent MI. Then check out all the risk factors. Example, we have seen what are risk factors: smoking, alcohol, drinking, sedentary lifestyle, high lipid level. These are many lipid factors. Try to control these. Then add aspirin 81 milligram once a day. If it is not contraindicated, if there are no gastric ulcers or such things, or no bronchial asthma or such thing where aspirin is not given. If it is problem, then go for clopidogrel. Simultaneously go for cigarette smoking. If it is difficult, then there are some drugs are available, some nicotine patches are available. We call them as a smoking cessation program. So give such drugs which will able to reduce the cigarette smoking desire. Go for diet, exercise and weight reduction. These are all lifestyle modification: DASH diet, adequate exercise and weight reduction. Then elevate LDL cholesterol, or if such things are there, if cholesterol is higher, then go for anti cholesterol therapy or anti-hyperlipidemic therapy, and check various guidelines for that. Accordingly, various drugs are there. Example, statins are there, fibrin are there, fibrates are there, niacin is there. Then so many drugs are available. Out of that, most popular, most widely used are the various statins. If blood pressure is high, then go use various recent GNC guidelines and accordingly go for it. We have seen it in hypertension. Consider AC inhibitor or ARBs, and then if it is okay, then go for routine follow-up. That is, and it should include everything. Routine follow-up means check all the things, go for all checking, check heart function, check the diet and all, get information about it, exercise, diabetes if it is there, check all this management. So this is the brief algorithm for coronary syndrome or acute coronary syndrome. Now in all over, this is not only for this therapeutic class, but even in future, whenever it is there, we call this as evidence-based medicines. Evidence-based medicine means what? Actually, this is a whole chapter in your 4th year. But let me tell you how the drugs are finalized, how the first line, second line treatment, or the most appropriate treatments are finalized. So what it is there? So class 1 drugs are the drugs which are having comparatively much benefits than the risk. So benefit to risk ratio is very high is one thing, and second thing is it has been proven at various places. So this it is not a theoretical one, it is not pharmacology of this and pharmacology of this, but what is actually happening. If you remember in hypertension, we have seen that although we have not studied diuretic detail about diuretics as an antihypertensive agent in pharmacology, because it is coming in the diuretic chapter, but it has been found that thiazides are the most important, most effective agents in hypertension treatment, and it has been proven in many trials. Several trials show that this is the best drug, thiazide diuretics. So that means here it shows that benefit to risk ratio is very good. It is very high benefit, comparatively lower risk, and second thing is it has been proved in most of the trials. So that is, these two criteria are there. Accordingly, class 1 drug, then class 2 drug, where the benefit to risk is comparatively not as big as class 1 drug, and it has been found that various studies, additional studies are there which should be added, because in first class all the studies or most of the studies are showing there are more than three or more than three studies are there where number of subjects are quite adequate and really well documented, well prepared study is there, that is class 1. Comparatively everything is less, benefits are comparatively less than first, then the documentation is comparatively less, and some scientists feel that some even additional studies are required, some few things, some questions are not answered properly, then it can be there, and it is reasonable to perform procedure or administer treatment because it has got lesser problem. This is known as a class 2A drugs. Class 2B are having benefit is slightly greater than risk. It is not a very big difference between benefit and risk, and therefore still additional studies and additional registered data should be there. More studies has to be conducted, more number of patients, more places are there, and the procedure or treatment is there. So here what is there? Here class 1, therefore procedure should be procedure or treatment should be performed or administered. This is first choice. Class 2A becomes second choice. So it is reasonable to perform the procedure, or it is reasonable to administer the treatment because it is beneficial. The third one is it can be considered, it may be considered. Okay, and fourth is risk may be greater than benefit. There are no additional studies are needed. It is very clear that there are no benefits, and in that case this should not be used, it should not be performed, or the drug should not be administered because it is not harmful, rather it may be harmful. So these are how evidences are collected, and on that basis we are going, on the basis the drugs are preferred, drugs are either drug or procedure. Procedure means what here? Procedure means, example, we have seen that in case of angina or myocardial infarction, people are going for various procedures like angioplasty, PTCA, or even we call it as a PCI, or we are going for another procedure that is called as a CABG, that is coronary artery bypass grafting. So these are the procedures, and treatment means either thrombolytic, this drug or that drug, this is all, that is the treatment. So treatments are administered or procedures are performed. So these are the things, accordingly we can take decision. Additionally, what should be there? That is, we should go for cigarette smoking cessation, blood pressure control, lipid management towards normalcy. We should set the goal for that. Just like blood pressure, we have set goal that reduction by around 20/10, means 20 millimeter of systolic and 10 of diastolic, like that. Weight management should be there so that we can have the weight reduction by maybe 10 kilo, 20 kilo, depending on that in a given period of time. Diabetes management, that is how much blood sugar can be controlled. Then giving the antiplatelet agents, anticoagulants, RAS system modulators, that means either AC inhibitors or ARVs, beta blockers, influenza vaccination. These are various ways. So guidelines, there are very important. ACC means what it is, American College of Cardiology. AHA means American Heart Association. Then American Clinical Pharmacist. These are various associations, and they come together to make the guidelines. So what these guidelines says, use the ABCDE approach. What A means? A is anticoagulants. Example, aspirin and other anti-anginas. B means beta blockers. C means control of cholesterol and cigarette. D is diet and diabetes. E for education and exercise. So these are the 5 main things which is to be done for angina. Now one thing again keep in mind, that angina and myocardial infarction, that way both are similar. Only difference is angina may remain in body for many years, even sometime throughout their life the patient may not have any problem, because maybe during a very strenuous exercise it is happening, and then in that patient, if the plaque site is not growing, or there is no big coronary artery spasm, then the symptoms may appear in few times and it will go away. However, myocardial infarction is having similar problem, but it is acute. All of a sudden there is a major block of some of the area, some of the arteries, and that can lead to even death. That is what big difference is. Angina slowly growing, if it is increasing, it can become the problem, and it can show similar sign that of myocardial infarction, or as I told you, acute coronary syndrome. So we have seen this classification earlier. 1 means which are most recommended, 2 means they are good, 3 is okay, acceptable, and 2B is acceptable, and 3 is not at all acceptable. It is not this one. So first class we are having A. A means anticoagulants like aspirin, clopidogrel, and many others. So what we are going to do about it? So they are again class 1 recommendation. That means they are having more benefit, much more benefit than the risk. So accordingly, in various cases, what we are going to do? So whenever it is there, whenever either angina MI is there, start and continue indefinitely aspirin 75 milligram to 162 milligram per day in all patients, unless the aspirin is contraindicated. In some patient, like as I told you, in asthma and other cases, it is contraindicated. For patient undergoing CABG, that is what, coronary artery bypass grafting, aspirin 100 to 350 milligram can be given within 48 hours after surgery to reduce the saphenous vein graft closure. Post PCI stented patients should receive 325. Post stented means PTCA or PCI, where stent has put in 320 milligram per day aspirin for 1 month for bare metal stent. There are 3 types of stent. If you remember, I told you there are 3 ways. One is simple stent, that is metal stent. The second one is called as a sirolimus or drug eluting stent. There are 2 types of eluting. Eluting means which are releasing drugs slowly. So 3 months for sirolimus eluting stent and 6 months for paclitaxel eluting stent. Now this stent, why drug eluting stents? I told you these are the immunosuppressant agents. So why we are going for this immunosuppressant agent? Because whenever the stent has been put over there, it can be taken as a foreign object, and once it is taken as a foreign object, then there will be gathering of these various blood cells and cytokines, and because of that it can cause growth over there. We call it as a restenosis. Restenosis means again around a stent, just nearby the stent there can be growth of tissue, development of tissue, and if the tissue is developed, it will develop plaque-like tissue, and that can be again dangerous one. So there won't be any effect, any impact of that. So it takes around 1 lakh rupees for this angioplasty, and if this angioplasty is failed within few days because of this type of regrowth or restenosis, then it can be useless, and people will be not getting it. So for that, the thing is, the drug is given aspirin for some time, 1 month, 3 months, 6 months, depending on the type of stent, and the drug accordingly stents are used which are releasing the drug in that area, and because of the release of drug in that particular area, this will not allow the restenosis. So this is why we are using sirolimus eluting stent or paclitaxel eluting stent. Now what are the evidences? As I told you, our therapeutics is a evidence base. We may learn so many things in pharmacology, but then we are going in therapeutics after all evidences. So what evidence says? Evidences shows that there are reduction in the odds, that is the number of patient. The odds ratio is one of the calculation. So odds ratio means how much are getting benefited in that particularly this one, or if we compare it, what are the benefits and what are the disadvantages, or risk benefit, how it is. So in that we can see that, or it can be easily seen that this shows that in myocardial infarction it shows towards benefit size. Okay, acute stroke, it is not that beneficial. Before myocardial infarction, this is the line of benefit that shows that yes, it shows benefit. Then prior stroke or transient ischemic attack, it is beneficial. It is very beneficial in coronary artery diseases, and it is not that effective like intermittent claudication in peripheral artery diseases. It is not very effective in high risk embolism like atrial fibrillation, and they are rather not preferred in case of diabetes mellitus. So this odds ratio, this is a statistical way by which we go for, or we try to understand that what will be the odds, what will be the benefits, and what will be the losses. So this odds ratio show very clearly that this will show the benefit in the people. Now aspirin evidences, the dose and the efficacy. If somebody goes for that, it will find that the dose from 75 to 150 mg is one of the best drug possible. Then next is after that is 160 to 325. So always the dose should be in the range of 75 to 350 milligram and should not go beyond that. These are various number of trials which were conducted. Those who have tried to go for higher doses like 500 to 1500, even there are so many number of more trials, still it has been shown that they are not effective, rather they are harmful. So these are various ways which indicates that what should be the dose. These are again different studies. They will be indicating that the dose range from 75 milligram to 350 milligram is the best. Now beta blockers, we know that what are their mechanism actions. They are working at many places. They can reduce the heart rate, they can decrease the afterload, they can reduce the wall stress, they increases the heart size. Because of that, they decreases the contractility, they decreases the wastage of oxygen, means unnecessarily too much energy is not consumed. There is a increased diastolic perfusion. The perfusion means during diastole the more and more blood can reaching to various tissues. It causes less exercise vasoconstriction, and it causes whenever there is a more spasm, it decreases it. So these are various activities. Thus it reduces demand by many folds, and it just slightly try to help in supply. We have seen the gap of demand and supply during angina. So its major activity is reduction in the demand and slight one, somewhat action in the change in the supply overall if we make the calculation. It can also reduce the oxygen deficit, and it helps in the anaerobic metabolism, thereby improving the energy component. Then therefore these beta blockers are useful. They are playing very, very important role. Now what is the recommendation, what it shows? So it shows that in angina, whenever start and continue indefinitely in all cases, post MI, then acute coronary syndrome, then left ventricular dysfunction with or without heart failure symptoms, unless it is contraindicated, then go for this chronic therapy. For all other patients with coronary artery or vascular diseases, along with or without diabetes, unless it has been contraindicated. I told you in what cases beta blockers are contraindicated: when asthma-like situations are there, and when beta blockers cannot be tolerated, then we do not give them. So what shows the impact, that is various phases, and what are the treatment? If it is acute treatment, around 28,000 or 29,000 people has found, and it has been found that it has been very effective. In secondary also it was found to be very effective, and thus it shows very, very good beneficial effect. The beta blocker evidences post myocardial infarction. After myocardial infarction, it can be given as a supportive therapy, almost lifelong it is given. So carvedilol post-infarct survival control in this left ventricular dysfunction. The carvedilol is one of the beta blocker, and when it is prescribed in the patient who are survived from the left ventricular infarct, and there is a left ventricular dysfunction is there. Then there was a big study was there, and this study was showing the effect that there is a benefit of that, that is how much events were there, event free periods are there. So in that we can say that carvedilol will have, they were having more event free period or less as compared to placebos. So these are the benefits which are offered, which are shown to be better than this one. Then next is various studies. This shows what are the studies. These are all short forms of the studies like CVS, CVS2 based, MERIP, MDC, Capricorn. Here C Capricorn means what? Carvedilol post infarct, CPI, survival control of dysfunction. So these was Capricorn studies. Then US carvedilol study, then Copernicus studies. So these were various drugs in which the drugs which were used like bisoprolol, metoprolol, carvedilol. What was the situation in heart failure, moderate to severe or severe heart failure? For how many years the follow-up was done? What was the doses, and what has the final effect? So it causes the decrease in the mortality. 20 means number of death they are increased. That is 22% changes, then 34% changes with bisoprolol, then 10% with this bisindolol, and like that. So there are various studies, and these studies shows these are the level of significance. P is equal to 0.001 or P is equal to NS means non-significant. If it is non-significant, then it does, even though there is a effect, we do not accept it. We say that it can be by chance. It is not acceptable. But if it is significantly, when P is less than 0.05, then we say that no, yes, now we can say that the effects are not by chance. The effects are actually there, and we can trust on these effects. We can put that yes, these effects are okay. So these are various studies they are showing. Then how blood pressure control regimen are there, or how we can recommendation it. We have seen that we try to make the goal of 140/90 or 130/80, or what we have tried is reduction it by 20/10 blood pressure. What's your blood pressure was there? Our goal was minimum 20 of systolic and 10 of diastolic should be reduced, and then we can go for the further addition or changes into it once it is stabilized. So these are various drugs which can be given, and simultaneously lifestyle modification like weight control, increase in the physical activity, alcohol moderation, sodium reduction, increased consumption of fresh fruits, vegetables, or low fat dairy. These are various ways by which we can go for blood pressure. When it is more and simultaneously there is a CKD or diabetes, then we are going for AC inhibitors and or ARBs, and then simultaneously thiazide diuretics or other diuretics we are using. These all guidelines we have seen in blood pressure. Why we are discussing, or why we are discussing blood pressure here again? Because we know that the change in the preload and afterload is very, very important. It is very crucial in cardiac treatment. So we are trying to, and if the blood pressure is remaining higher, then it is affecting the function on the heart. Chakradhar. Chakradhar, mute your mic. So the importance in that is why we are controlling blood pressure. We have seen that these are the reason why we have to control it. These are the results again. When blood pressure is controlled, what are the impact on the death of people? So ischemic heart disease mortality, you will see that in various cases. And what was the age of the person? Group was suppose 42, 49, 52, like that, these were the age, and blood pressure increase. So at every increase in the blood pressure, the rate of death was increasing. Okay. So suppose the age is 40 to 49, blood pressure is 120, so hardly one or other person will die. See, this is the exponential increase. But okay, now if it is 50 to 59, then it is around 2.5 or 3 people will die. It is around 9 people or 10 people will die. Here around 32 people will die, if, even though they are having almost normal blood pressure. And if the age group is 80 to 89, around 60 people will die, because other complication will be there. But now group wise, again in same group, this 40 to 49 group, if the blood pressure is increasing, then if blood pressure reaches to around maybe 160, okay, then instead of one, there will be more than 3 to 4 people will be dying. Here around 4 people are dying. So this is how the impact is there. That is increasing the mortality by many fold. Therefore, we are treating hypertension for ischemic heart diseases or the coronary artery diseases. I hope you understood this, that why we need to treat the hypertension simultaneously, because it is one of the very important feature, and it puts workload on heart. So if we reduce it, if we can make it optimal, then it will be the best one. So these are various studies, many clinical trials. They show that if we go for control of blood pressure, it will be better one. Otherwise, the risk of coronary artery disease will be increasing. This is what we already studied, various hypertension managements, how we are doing, what are various drugs, what are various types of hypertension, and which drug we are going to use. We have seen almost variety of classes, and in which condition, if it is angina, if it is MI, if it is CCF, which kind of drug we are going to give. This is we have already studied. Then lifestyle also we have studied for hypertension, various diets, and what are going to do, what are our goals which were set with various diet plans. Then what are the indication of the drug classes, that is compelling means, that means that in that condition the drug has to be given, and that particular drug has to be given. So example is compelling indication is heart failure. That means heart failure is there and patient has to be treated. This again will cover in heart failure also. Then the treatment should be diuretic, beta blockers, ACE inhibitor, or ARVs, or aldosterone antagonists like spironolactone. There are so many studies which have done it. The name of these studies are Merit, Copernicus, CBIS, Solvo, Trace, Rails. These are all studies which are there, they are showing it. Then the person who have survived from myocardial infarction, there was myocardial infarction, but now person is good. Person is recovered from this trauma, but then we need to give some treatment which will be helping the patient out. So these are the example of these are beta blockers, ACE inhibitor, or aldosterone antagonists. There are various studies which were there against SAVE, Capricorn, Ephesus, then ACC/AHA guidelines. These are various places from which this indication is there. Then where the person which are having high coronary artery disease, means which are known for diabetes, which are having atherosclerosis or hyperlipidemia, although today it is not there, but there are every chance. Then in that cases we are going for diuretic, beta blocker, ACE inhibitor, CCVs, and there are variety of these trials are there like ALERT, HOPE, NBP2, LIFE, CONVINCE. Those who are interested, they can just put it in Google search, and like name of trial, ALERT trial, HOPE trial, LIFE trial, CONVINCE trial. So they will understand, and along with heart, you put that, or heart problems. So you'll realize what these studies are, how many patients were there, and how these studies are actually conducted. Then diabetes, if it is there, then definitely along with diabetes treatment, what's your treatment which is there for diabetes mellitus, along with that, what are the recommendation are diuretics, beta blockers, ACE inhibitors, then angiotensin receptor blocker, calcium channel blocker, and again there are various guidelines like UKPDS, ALERT, NF, NKF, etc. Then chronic kidney diseases, ACE inhibitor, ARBs, again there are various trials, and recurrent stroke prevention. Then we have got drugs like diuretic or ACE inhibitors. The name of trial was Progress. So there are various trials. These are the evidences we can, and on the basis of these evidences, we go for assessment of benefit and risk. If more benefits are there, then this treatment is coming as a guideline or in the form of algorithm. So cigarette smoking is there, very, very important, and the effort should be made to make the person quitting the smoking. Whatsoever treatment is required can be done for that. There are various ways by which it can be done. There are various pharmacological treatments are also available, like nicotinic replacement treatment or bupropion. There are patches are there, and like that, various ways, counseling, etc. All the measures should be taken, and it should be seen that patient is quitting tobacco. So it has been found very beneficial to have the benefits of cigarette smoking quitting. Lipid managements, again lipids are playing a very, very important role, as we have seen as atherosclerosis. There are many other things they are doing. If lipid is there on the arteries, then arteries will not able to secrete nitric oxide, and since it will not able to secrete nitric oxide or release nitric oxide, this nitric oxide will not able to act. They are vasodilator, and they will cause the rigidity or stiffening of the arteries. Arteries should be elastic, arteries should be very good flexible. So this all flexibility is lost, and they will remain in a contracted position. So in that cases, we should go for the drugs which are lowering these various hyperlipidemias or triglyceridemias, and so that it will reduce the risk for the patients. So what are the lipid managements? Go for diet therapy, so that reduction in the calories and various fats. Add the plant stanol sterols into it, so that it will be beneficial, it will lower it. Promote daily physical activity and weight management. Increase consumption of omega-3 fatty acids, and accordingly it will become antioxidant effect, and dietary help will be there. So there are various treatment also can be there, and accordingly the LDL treatment or LDL has to be reduced. Same is the case with the triglycerides. We should try to reduce triglyceride, and set the goal and make the efforts to reduce this cholesterol for various ways, various drugs, single or multiple it can be added. Example of this, we can see that there are more drugs are there, more intense therapy is there, then niacin can be added into therapy, or fibrates can be added. And if the triglycerides are more than 500, then it should be, options are there to prevent pancreatitis or fibrate and niacin before LDL lowering therapy. So these are various effects which are, these are various drugs which has to be studied or which has to be used. So most prominent in that are statins, as I call them. We call them as a HMG-CoA reductase inhibitor, or statins. Lovastatin, atorvastatin, flevastatin, pravastatin. So many statins are there. So let us, any of these statin which is the most preferable can be used, and it can be reducing the hyperlipidemia, and because of reduction in the hyperlipidemia, it will prevent the chances of atherosclerosis, and if it prevents the chances of atherosclerosis, it will reduce the hypertension, it will reduce the chances of angina or chances of any other such kind of cardiovascular disease. So it was a comparison between pravastatin and atorvastatin in the various treatment, and almost they were parallel. Very small difference was there between them. Then the benefits of HMG-CoA reductase inhibitors. So they are useful. They show good signature, good signs, and they reduce the level of LDL, and therefore they reduces the event. You will see that the most of these green dot are there. That means here lipid level were controlled because of these drugs, and because of that the event level will also, they were also controlled, while here the event layers are comparatively more, and these are red dots where they were placebos and there were high level of lipids or LDL or cholesterol lipids. So that means lipid lowering was very helpful in reduction in the various cardiovascular events. So what are these drugs which are there, which are used for lipid management? So statins can control total cholesterol, LDL, HDL, triglycerides, and they are very good tolerable to patient, and they are able to reducing around this much level, that is reduction in triglyceride by around 19 to 37%, LDL by 25 to 50%, HDL increases by 4 to 12%. HDL is good cholesterol, we say, and the triglyceride less by 14%, and overall tolerability is good. Then another drug is known as ezetimibe. This ezetimibe is causing it 13% lower in triglyceride, 18% lower in LDL, 1% increase in the HDL, and 9% reduction in the triglyceride, having good acceptability. Then bile acid sequestrants, they are around they can reduce it by 7 to 10%. LDL they can reduce 10 to 18%. HDL they can increase by 3%. And triglycerides, they do not have big effect on triglycerides, but they are having good adverse effects, and it is not tolerable well. Then nicotinic acid, it is you can see that triglyceride it can make total cholesterol it can make 10 to 20%, LDL it makes 10 to 20% reduction, HDL it can increase by 14 to 30, which is very high, and it can reduce triglyceride by 30 to 70%, but only biggest problem is it is quite toxic. It has got many adverse effect, and it is reasonably poor in the patient tolerability, and fibrates are the another drug. So that also having almost good sign, good range of activities. So these are various drugs which are used for lipid management. They are very important, and what are the goals are there, why we are giving this? So we want to maintain the lipid level. The goal is it should be less than 100 mg per dl, and further reduction of LDL-C to less than 70 mg is a reasonable one. So for that we are giving treatment, and it can be achieved. Simultaneously dietary recommendations are important, and accordingly if best diet plans and all this lifestyle management plus drugs are there, then it can help. Then next is weight management program. That is also important. The weight should be managed, and accordingly it should be made it in a control one. There should be reduction in the baseline basic metabolic index. Then the waist circumference should be reduced, and all these activities are done so that the patient's or the person's weight is in control, and this is very important. So this is body mass index. When there, then it makes the problem. These are various measures for that simultaneously, and what should be our goal, what are the limiting areas. These are the chart, it is showing it. Then next is metabolic syndrome, which is very common, which is called as a very dangerous one. These are three things simultaneously occurring: diabetes, atherosclerosis, that is, or hyperlipidemia, and hypertension. So this is called as a triad, and this is very dangerous one, because all these are initially they are not showing any symptoms, and they can call as a silent killer, and when these three combine together, it can be creating a havoc. It can lead to very big problem to the patients. So for that, the measures which are taken, that is placebo, metformin, and lifestyle metabolism, so that diabetes can be controlled, and automatically one can try for going for hypertension and other thing control. So what are the recommendations? That is lifestyle and pharmacotherapy to reduce the HbA1c or to bring it to the normal. HbA1c we shall see during diabetes. Then vigorous modification of other risk factors like physical activity, weight, etc. Modification means so that more exercise can be allowed, more exercise can be given to the patient, so that can reduce the fats also, can reduce the body weight also, and get these benefits of the exercise. So these are various physical activities, they are also important. Various exercise and all activities, they are equally important, and they should be done. The patient should be encouraged to do it. So these are various activities, and if these all things are there, then one can definitely reduce the mortality. And the next thing we shall see in our next lecture, then what will happen because of the other activities like various drugs and activities. So here we finish today's class. You please go on reading, and if you have difficulties, you can ask me.